Okay, good morning. Thank you for the presentation. And I will talk about embryoscopy. It's a novel technique for the mistreatment of misabortion. And the learning objective of this talk is that we understand the concept of embryoscopy, know one of the techniques available for embryoscopy, identify key steps of embryoscopy procedure, and understand the potential advantages of embryoscopy. First, early pregnancy loss is a spontaneous loss of pregnancy before 24 weeks of gestation. Is most frequent complication of pregnancies, more commonly observed during the first trimester, and is present in 25 to 30% of all pregnancies. Miscarriage has a significant psychological impact on women and their partners. 9 months after miscarriage, women have high risk of depression, anxiety, and risk of suicide. So I think miscarriage matters. It's something that we have to take into account. The diagnosis of the cause of the miscarriage could help patients overcome the event, help patients prepare for the future pregnancy, and could help the medical team to propose diagnosis workup and develop a treatment plan for the patient. We know that 50% of the miscarriage will be caused by chromosomal abnormality, most common numerical abnormality in 89%, trisomy, monosomy, and polyploid embryos. And we know that with age, this percentage of causes of abnormal genetic causes is greater. Even with 41 to 44 years, it will be like 75% of the causes will be because of genetic abnormalities. So what's embryoscopy? Embryoscopy was first described in 1990 by Callen and consists of a uterine evacuation of a product of a conception performed under hysteroscopic guidance. This is a study published in 2017 by Feitzinger that published this article of 984 embryoscopies, and he showed that the genetic results were in 98% of the cases, no maternal contamination, no complications. So based on the description of this technique, we were able to publish a video article in April in 2025 in Fertility and Sterility. It's a video. I will put it now. I will play it now. It's not, the English not as good as Jairo's Phoebe, but I hope you enjoy it.
Surgical video tutorial about hysteroscopic uterine evacuation in cases of misabortion under transabdominal ultrasound guidance. Patients included in this video gave consent for publication and posting of the video online. 1 of every 4 pregnancies ends in a pregnancy loss. Chromosomal analysis of products of conception plays a fundamental role in the evaluation and treatment of pregnancy loss. Traditionally, POC samples are obtained through dilatation and curettage. However, embryoscopy has emerged as an alternative. Transabdominal ultrasound guidance has been proposed to monitor hysteroscopic surgeries. However, its use during embryoscopy procedures has not been described so far. The objective of this article is to describe the hysteroscopic ultrasound-guided removal of misabortion, with a video that illustrates step by step this technique. Embryoscopy is indicated in early pregnancy loss with the presence of an intrauterine gestational sac between 5 and 10 weeks determined by ultrasound measurement. Is contraindicated in cases of heavy bleeding and signs of pelvic infection. We perform embryoscopies under deep sedation with a full bladder under transabdominal ultrasound guidance with a 5 mm compact hysteroscope. Forceps and scissors are used for sampling and dissection. Continuous normal saline flow is used with a pressure ranging from 80 to 100 millimeters of mercury. We start with a 80 millimeters of mercury pressure setup. If there's no adequate distension or visualization of the gestational sac, we increase the pressure. This slide illustrates the anatomy of the early gestation. We can see the extraembryonic cellum, the amniotic cavity, the embryo, and the yolk sac. When we perform an embryoscopy, first we enter the extraembryonic cellum. Then we can see the yolk sac, the amniotic cavity, and the embryo. This is a case of early gestation. We can see the yolk sac, the amniotic cavity, and the embryo. Step 1. We perform an abdominal ultrasound previous the hysteroscopic entrance to confirm the presence of misabortion and localize the gestational sac and the embryo. Step 2. Hysteroscope entrance. Anatomy of the cervix and uterine isthmus change during pregnancy. That's why, in this step, ultrasound guidance is of paramount importance. We can see clear the tip of the hysteroscope by ultrasound and how we have to go in to reach the gestational sac. Hysteroscope entrance view is not clear as in other hysteroscopic indications because of the anatomical changes of pregnancy. On ultrasound guidance, we can clearly see the tip of the hysteroscope and we can see where we have to go to reach to the gestational sac. Step number 3 is the localization and opening of the gestational sac. We localize the gestational sac and evaluate implantation. Then we open the sac with scissors, making a 5 mm hole, and we go through it with the hysteroscope, entering the extraembryonic cellum, and then we evaluate the different structures from the early gestation. We can see the yolk sac, the embryo with the very small amniotic cavity, and the umbilical cord vessels. Step 4. Embryo grasping. We grasp the embryo with forceps and go out with the entire stethoscope and deposit the sample in a correctly labeled container. Step 5. Chorionic villus sampling. We enter again with the hysteroscope and localize the chorionic villus. This is the chorionic villus shape, so when we identify the chorionic villus, we grasp the villus with forceps and go out with the entire hysteroscope and deposit the sample in a correctly labeled container. Step 6. Gestational sac dissection. We can do this step with forceps or scissors. We separate the gestational sac from the decidua and then grasp the sac and go out. This is another case in which we did the dissection of the gestational sac with scissors. Step 7. Gestational sac extraction. In some cases, the extractions can be done just grasping the sac and going out. In other cases, we can't get out the sac because of the sac volume or poor quality view because of bleeding, as we can see in this video. In these cases, we use a 6 mm aspiration cannula connected to a control pressure vacuum. The objective is not to do a curettage. We aspirate inside the cannula the already dissected sac for extraction, trying to do no harm to the endometrium. Now we will give you some tips and tricks of this technique. Sometimes the sac could collapse. A better way to solve this problem is to
we published this other study
localize the gestational sac by ultrasound.
We have two parts in this study. The first part was we already have 20 cases that we analyzed with ACG, and we analyzed it with NGS. This part of the study was a retrospective analysis of these 20 cases, and the second part we do it all with NGS. We analyzed the samples of the results of the 21st embryoscopy results and 54 cases analyzed by NGS. What we do with the first 20 cases, we did the DNA extraction was done by Genoma Lab. The result was done with ACGH, and then this same DNA was transferred to Cooper Surgical, where the analysis was performed using PGT-A 2.0. It's a platform made for PGT analysis of the embryo, but it's an NGS technique that incorporates artificial intelligence into the analysis process of the NGS. And what we found is we had one case of maternal contamination in the ACG analysis, but when we analyzed this case with NGS, it was informed like mosaics of the 16 and of trisomy of 16 and monosomy of X. What can happen? How can we explain this? Mosaics embryos show weaker signal because there are less cells that are genetically abnormal and could be misdiagnosed by ACH. However, NGS has higher sensitivity, higher specificity, have higher resolution and broader coverage. So that's why maybe in mosaics could have a better results than ACGH. In the 19 results that we have from ACGA and NGS, only one case we have a discordant case. And it was informed in the ACGH as a mosaic, but in NGS it was informed like a euploid embryo. In the other 14, when we compare the type of aneuploidy diagnosis between ACGH and NGS, we observed that in these 4 cases, NGS identified mosaics and polypoids embryos that haven't been diagnosed as only trisomies in the ACGH, as we know, because it's better in mosaics diagnosis. And when we analyze the 74 embryoscopies that we include, the mean age was 39 years old, a range between 32 to 51 years. The mean gestational age was 6 weeks and 6 days. The range was from 5 weeks to 9 weeks and 5 days. And the CRL mean was 9.2, and the range was 1.7 to 29 millimeters. 33% of the pregnancies were by artificial technique, by IVF, insemination, egg donation, or PGT. And the results were that 58% of the result were abnormal genetic result, and 42% were normal. The frequency of the type of abnormality, we can see that the most frequent was trisomy 16, then 22, and monosomy of X. There were more frequent aneuploidy than mosaics and structural anomalies. There were no intraoperative or postoperative surgical complications observed. And we did 3D ultrasound 2 to 4 weeks after embryoscopy. And all patients, and 100% of them, has another normal uterine cavity after. 60 patients have a sonography after embryoscopy, 6 to 10 weeks postoperatively. There were no intrauterine addition or no retained products of conception. And about the fertility after embryoscopy, 57 patients attempt pregnancy after the procedure, and 86% of them get pregnant, and 98% of them have a live birth, only one have a miscarriage. And now to compare this technique we don't have studies that compare directly embryoscopy with DNC, but we can see that DNC have possibility of the percentage of uterine perforation goes from 0.5 to 1.9. The possibility of retained products of conception could be from 18 to 3.2%, and the percentage of intrauterine addition could go from 50% to 20%. So it seems that maybe this technique could benefits in terms of less uterine perforation, less retained products of conception, and less addition after the procedure. And what about, this is a very good study. They tried to do the genetic results with the products of conception could be by DNC, or the patient have a medical abortion, and they take the sample and analyze, and they found that 40% of the patients have no result because of maternal contamination. And when we do DNC and ACH, 50% of the patients of the results were maternal contamination, and DNC with ACH in gestational age lower than 7 weeks, 24% of them have no result because of maternal contamination. So that's why embryoscopy, if we want to have a result and have no maternal contamination, is a good option. And the take-home messages are that embryoscopy is a safe procedure with a very high success rate and no maternal contamination. Embryoscopy appears to be associated with a low rate of post-operative complication, including retained products of conception and intrauterine additions. NGS demonstrate high concordance with ACH, but NGAs provide improved detection of, have higher sensitivity, resolution, and better identification of oocytes. Thank you.